Hello guys, good afternoon. I hope you are doing well. Today I will be discussing chest pain stations. So today we'll discuss cardiology, we'll discuss chest pain stations. Okay, in clap 2, chest pain is very important, chapter, and I would like to tell you that it's very important because you need to show that you are a safe doctor. Okay, now let's start. If a patient is coming to you to the clinic, GP clinic, or the A&E is coming to you with chest pain, how can I approach the chest pain stations and how can I manage chest pain stations? Chest pain is what? Medicine or counseling? Medicine station. So go back to the medicine structure. I have P1, P2, P3, Maftozan, okay? P1, P2, P3, Maftozan. P1 is the presenting complaint. How can I help you today? Doctor? Oh, doctor, I have a chest pain. Oh, I have a chest pain. So the patient is having a presenting complaint, chest pain. So before I do anything, sympathy and empathy. I'm really sorry about that. Are you comfortable talking to me? Are you comfortable talking to me, or would you like me to give you painkiller? If the patient said I'm comfortable, I will tell him at any time you are uncomfortable, let me know. If the patient said I am uncomfortable, I need painkiller, still I need to ask about the pain because the painkiller will mask the pain. So I will say to him, my answer will be all right. Is it all right? Is it all right if we have a chat about the pain itself in order to prescribe for you the best painkiller? And then at this moment, ask about the pain in details and give him painkiller as appropriate. So, how can I help you today? Doctor, I have a chest pain, sympathy, empathy, and then the first question, the first open question, can you please tell me more about it? Can you tell me more about it? Can you tell me more about it? So the patient will tell you more about his pain. He will give you some findings about his pain. So what do you use? Socrates. Please, in details, Socrates, site. Can you please point to one finger where the pain is? Onset, how did the pain start? Character, what type of pain is it? Radiation, does it go anywhere else in your body? Like your left shoulder or your left hand or your jaw? So radiation, okay? So anything that makes it better, anything that makes it worse. And when did the pain start? And on a scale from 1 to 10, 1 is being the lowest severity and 10 is being the most severe pain, can you please tell me how would you get your pain? So Socrates will be asked. But be careful because when you ask Socrates, I would like you to ask it in a way that you will also give differential. What do you mean, Dr. Mo? I will ask Socrates in a way that at the same time, I will be giving differentials. I will say to my patient, can you please point to one finger where the pain is? Side. Onset, how did the pain start? If the patient said to you, doctor, it started an hour ago all of a sudden. Now you're going to think of acute chest pain. MI kind of a chest pain. For example, acute, okay? Character, what type of pain is it? If the patient says, for example, doctor, it is sharp, it is stitching, it is as if someone is stabbing me, I will think of an MI kind of pain. Radiation, I will ask him, does it go anywhere else in your body? And I will specify. Your left hand, your left shoulder, your jaw, to exclude MI, guys, yeah? Or does it go between your shoulder blades to exclude aortic dissection? Then I will say to him, anything that makes it better by any chance, like painkillers, for example, or leaning forward, for example. So leaning forward to exclude pericarditis. Anything that makes it worse, okay? And then timing. When does it start? And then severity on a scale from 1 to 10. How would you grade your pain? So I will ask Socrates in details to gain some differentials. All right. Whenever I explore chest pain, I will ask the second golden question, anything else? Then the patient will give you some other symptom, for example, fever, for example, shortness of breath, whatever. Then tell me more, then explore. After, for any chest pain patient, after I ask about the pain and anything else, I have 5 symptoms. 5 symptoms, yes. 5 symptoms that they come together all the time. Blindly, whenever you have a patient with a chest pain, I will ask about any shortness of breath, any cough, any fever, any heart racing, and history of trauma. So 5 questions, they come whenever there's a chest pain, they come all together, they come right away after the chest pain. So if you have a chest pain, ask these 5 symptoms. What if you have shortness of breath? Ask the rest: cough, fever, heart racing, trauma, chest pain. If you have heart racing, ask the rest: trauma, fever, cough, chest pain. So they come together. So after the chest pain, I'll ask the 5 symptoms. And after that, and by the way, these 5 symptoms, again, they give me an idea about differentials. Without realizing, they are differentials. If you ask the patient about shortness of breath with a chest pain, MI, maybe PE as well. Cough, pneumonia, chest pain, cough, pneumonia. Chest pain, fever, for example, pneumonia. Heart racing, palpitation, AF. Trauma, history of trauma, chest pain, musculoskeletal. So basically, I will ask these 5 symptoms, and then I have already given some differential, and then I will start my DDs. So when I start my DDs, as you know, P1, tell me more, anything else, tell me more, and then the 5 symptoms, they come without thinking, blindly. Then I will ask about differentials. Dr. Mo, you have already excluded some differentials there. Yes, that's right. But I need to give you the differentials of the chest pain, and after that I will go to the main concern, and then P2, P3, maphtosis. So what are the differentials for chest pain, the causes for chest pain? Look at my chest, but by the way, bear in mind, I've already excluded some of them by asking the 5 symptoms and by asking about the chest pain characteristics. Look at my chest, and I will take the chest from outside to inside. From outside, skin, so maybe herpes. So skin. So herpetic neuralgia, for example, if the patient had herpes and is having chest pain. So skin. So any skin problem at all. Then after that, I will go to, under the skin there is bones and muscles. So muscles, musculoskeletal, and bones, history of trauma. After that, I will go underneath, there is heart and lung. In the heart, MI, yes, I've asked it already in Socrates. Pericarditis, yes, the heart and the covering. Yes, I've asked already in Socrates about pericarditis, that the patient asking him, is it relieved to lean forward? Then come to the lung. Cough, what happened in the lung? Pneumonia in the lungs, what happened? 3 P's. Pneumonia, P, cough and fever. Already asked, cough and fever. Pneumothorax, trauma, pneumonia, pneumothorax, PE, I've already asked about shortness of breath. Okay, so basically, I will go as well between the lung and the heart, esophagus, heartburn, as GERD, as a sort of chest pain, GERD, any burning sensation. So basically, these are the differentials for chest pain. So differentials for chest pain, any pain in the chest, look at your patient and say skin, musculoskeletal, muscle and bones, heart, lungs, esophagus. All right. So now these are the chest pain differentials, and after that I will go to P2. But how many differentials do I need? Do I need to ask everything? No. You need maximum 4 differentials, as I mentioned. Maximum 4 differentials, but always think of the worst. Okay? Whenever you have a chest pain, you must exclude MI. Whenever you have a chest pain, MI. MI is differential. So, whenever I have patients come with chest pain, you must exclude MI is a must. MI is a must, okay? Then, concern, don't forget, always concern come in P1. After that, P2. And don't ask about the concern. You say, apart from the chest pain, what's your main worry? Okay? Okay. Now, very important question when you have chest pain. Very important. Ask your patient early on, are you in pain now or not? Because if the patient is in pain now, it is acute. If the patient is not in pain now, you will think of something like stable angina. So always ask, are you in pain now or not? Anyway, then I will go to P2. P2 is past history of presenting complaint and past medical conditions. Past history of presenting complaint, have you had such pain before? Past medical conditions, I have 5 conditions I ask about is high blood pressure, diabetes, cholesterol problem, thyroid problem, and heart attack. P3 is DESA, plus or minus sexual history and IV drug abuse. Okay, DESA. DESA, I will only use it if the pain is chronic. I will never ask DESA if the patient is coming dying from chest pain. Imagine if the patient is dying from the pain and you're asking him, how is your diet? You do any form of exercise, it will sound odd because the pain is acute. So basically, DESA, D for diet, E for exercise, smoking alcohol, but never ask DESA if the pain is acute, severe, the patient is dying. Only ask if the patient is coming with pain, muscular, musculoskeletal, for example, if the pain is coming something chronic pain, stable angina, plus or minus sexual history and IV drug abuse. Sexual history I don't need, but IV drug abuse I will need. IV drug abuse to ask in a patient with the chest pain. It could be infective endocarditis. It could be many things. It could be that the drug abuse causing him to have heart racing, palpitation, chest pain. Okay. Maphtosa. M for medication. Are you on any medications? A for allergy. F for family history. T travel. O occupation. S social. A anything else. However, be careful because occupation and social will not be asked in a case of acute pain. You will never ask the patient, how is it affecting your life? How is it affecting your daily activity? Who do you live with? No. Okay? Only if the patient is chronic, if the pain is chronic. But medication, allergy, family history, must. Travel, occupation, psychosocial, maybe. According to the pain, if the pain is acute, you can ask. You cannot ask if the pain is not acute, chronic, then you can ask psychosocial. So this is the structure for chest pain. So if any patient is having a chest pain, explore, tell me more about it. When you explore Socrates in details, when you ask Socrates, try to specify, point to one finger, onset, acute or chronic, character. When you talk about radiation, specify left shoulder, left hand, left jaw, shoulder blade. When you talk about anything that makes it better, like leaning forward, anything that makes it worse, and then timing, severity, and then go back then to, and when you ask the patient anything that makes it better, like any painkillers, have you taken any painkiller for it? If he said yes, what painkiller? What is the dosage? Did it help? Always. So when you ask the patient anything that makes it better, always say like any painkillers have you taken? If he said yes, explore. Whenever the patient say yes, you must explore. So if the patient said yes, I've taken painkiller, explore what painkiller, what is the dosage, how much did you take, did it help? Then after that, I went to the 5 questions, which are shortness of breath, cough, fever, heart racing, trauma. They always come together. These 5 questions always come after chest pain and vice versa. If you have any of these symptoms, they will come with the chest pain. So anyone, ask about the rest. Then differential, and I said differential from outside to inside. Then main concern, don't forget to ask the main concern. P2, past history presenting complaint, past medical condition. P3, DESA. I said you don't ask if the case is acute. DESA, don't ask if the case is acute. But if it's a chronic, yes, do ask. Plus or minus sexual history and IV drug abuse. IV drug abuse is needed here because it's very important. Maphtosa, I said psychosocial, don't ask unless the case is chronic. Occupation and social. Alright, MAF, medication, allergy, family history. This is the differential for chest pain. So now after taking history, what we do is expectation. What are you hoping? What are you expecting from today's consultation? Expectation. And after that, go back to day 1. And after that, I will verbalize examination. So examination, I will verbalize examination. I will verbalize examination. When you verbalize examination, you need vitals as well as chest, heart and lung. And after that, I will give idea. I will ask, do you have an idea what's happening? Do you have an idea what's happening here? And then after that, I will give provisional diagnosis. Go back to day one, provisional diagnosis. I'm giving you the structure, provisional diagnosis. In provisional diagnosis, always I told you, always tell the patient what's happening. No idea. Then I'm suspecting a condition called such, give the name. Have you heard about it? No. Then explain it. Explain it in a simple words. Explain it. For example, if you're talking about MI heart attack, decrease in the blood supply that's going to the heart. Okay? Then provisional diagnosis. Then finally is management. Management will be different from one case to the other, and that's what will make the station different. So then I will start discussing one by one, and with every station, what I will do, I will give it a positive and management. Positive management. Positive management. With every single scenario, I will give you the positive findings as well as the management, okay? So let's start. Let's start. Let me tell you something quickly, okay? Number one, if the case is MI, which means 55 years old, presented to the A&E with sudden acute onset severe chest pain, talk to the patient and this is concerned. So MI case. So the first station is MI. So how can I help you? Doctor, I'm in pain. Severe pain, doctor. Severe pain. Sympathy, empathy. I'm sorry about that. I'm really sorry. I can see you are very distressed. Is it okay to talk? Or should I give you painkiller? No, doctor, you can't talk, doctor. Yes, doctor. Okay. I will start. Tell me more about the chest pain. Then, Socrates. When I ask Socrates, this case is MI. What is specific in history? In this case, central crushing chest pain, left shoulder, left jaw, left hand. Specific in Socrates. Okay? Then, apart from the chest pain, anything else like shortness of breath? Yes, positive. It will be positive. Cough? No. Fever? No. Heart racing? No. Maybe yes. Trauma? No. Then I will go to differential. In differentials, as I told you, from Socrates, I found that it's MI. Description. From Socrates, I found it's MI. So when I take few differential, musculoskeletal trauma? No. Skin lesion? No. When I ask about the 5 symptoms already, I know the patient is not going to have any infection, any signs of infection, no fever, okay? No cough, no fever, no signs of infection as pneumonia, trauma, pneumothorax, no. Then when I go to the heart, I will know it is a description, typical description of MI. Then that's differential, maximum. How many differential? 2, 3, 4, maximum 4 differentials. P2. Have you had this before? Yes, doctor. He will tell you, yes, I've had heart attack before, or I had MI heart attack before, or maybe no. Then when you ask about past medical condition, he will give you history of high blood pressure, diabetes, cholesterol. He will give you such past history. DESA. I said to you, DESA, you never ask here. You only ask DESA if the patient is stable. However, DESA will be all positive. So when the patient is relieved in management, you can say to him some lifestyle modification I'd like to discuss. How is your diet, exercise, smoking alcohol, and they will be all positive. It will be all positive. Diet, he's gonna eat lots of junk food, fast food, no exercise, he smokes, he drinks alcohol. Maftosa, medication, allergy, family history, he will have positive family history. That's in regards to the MI. In regards to the MI history, okay? Now, management of MI or unstable angina. Management of MI. 7 steps. By the way, after history in MI examination, yes, verbalize vitals as well as chest, heart and lung. You will be giving vitals, oxygen low, okay? Heart and lung. Then idea. Do you have an idea what's happening? No, doctor. Provisional diagnosis, heart attack, decrease in the blood supply. But please saying it in a way, I'm really sorry. It's a bad news. I'm really sorry. I'm suspecting a condition called heart attack, which means decrease in the blood supply going to the heart. The blood's not good enough to the heart. Management, 7 steps. MI, always follow the 7 steps. So MI management, admit. Yes, admit. Number 1. Number 2, I'll talk to senior. 3 investigations. In the investigations, blood, urine, stool, image. Blood, what blood do you need? All the blood, full blood count, cholesterol, blood sugar, kidney function, liver function. You need ABG, urea electrolyte. Very important, you need heart attack markers. I will measure it few times. I will measure it once and then after 4 to 6 hours. So serial measurement for the heart attack markers. That's in terms of the blood heart attack markers. Clotting profile. So don't forget heart attack markers, clotting profile. Now, urine nothing, stool nothing, image, chest X-ray and the ECG, very important. Chest X-ray and the ECG. Can the ECG be normal? Yes, the ECG can be normal. And then I will repeat the ECG again. So the ECG can be normal and the patient is having heart attack. It's called non-ST elevation MI. So it doesn't mean that the ECG is normal, that the patient does not have MI, all right? So then, step 4, symptomatic treatment. Mona, morphine, oxygen, nitroglycerin, aspirin. Mona, okay? Step 4, referral to cardiologist, heart specialist, who will do further investigation like echo, and the further management like angioplasty. What is angioplasty, doctor? It is a camera test, a tube with a camera, flexible tube with a camera on top, okay? Will pass it through blood vessel in your thigh. Why? Will pass it to the blocked blood vessel in the heart, and then will inflate it in order to open the blood vessel, and will make sure you put a stent so it doesn't close. Okay, now that's for further management cardiologist. Very simple, easy way of management. Okay, then further the patient will need, when the patient go home, he will need further medication like what? Like A, B, C, D. A, he will need to be on aspirin or clopidogrel. Aspirin and atorvastatin. A. That's further. When you go home, you will be on long-term medication like aspirin or clopidogrel and atorvastatin and the ACE inhibitors. A, aspirin, atorvastatin, ACE inhibitors. This patient will have risk factor of blood pressure high, ACE inhibitor. Aspirin, yes, and atorvastatin. B, bisoprolol, yes. This patient will need to be monitored and will need to be managed for blood pressure. He will have blood pressure. C, clopidogrel, yes. D, DESA. So these kind of things, it is a follow-up. You don't need to talk about it. It will be long-term management. Don't forget to talk about driving. MI patient not allowed to drive for about 4 to 6 weeks and not allowed to go to work for about up to 6 months. Okay? Safety netting all the time for MI. Safety netting for MI. If you have central crushing, chest pain, going left shoulder, the same as this one, please come right away. Okay. Now, the second case is unstable angina. Only one difference, I would like you to know that in the unstable angina, the symptoms are at rest and lasting for longer than 30 minutes. So the unstable angina and the stable angina, these two conditions that I would like you to know. Unstable angina has not appeared in the exam yet, but I would like you to know one difference between the unstable and the stable. Stable angina is my second case, but stable angina is chest pain on exercise. So when the patient does exercise, they develop chest pain. The unstable not related to exercise. They can have it at rest. Okay? So that's the difference. So now the second case is stable angina. The first case is MI. MI present to A&E. Stable angina will present to the GP clinic. What is the difference, Dr. Mo? A&E, guys, severe central crushing chest pain. A patient is distressed, A&E. But the GP clinic, no, the patient had pain during exercise. When he had a rest, the pain is relieved. So they always make a call, GP clinic, then they get an appointment, then they come to the GP clinic. So the patient will come to in the GP clinic, number one, difference between MI and stable angina. The patient will come in the GP clinic, GP. He is not in pain now. The most important question, when the patient is coming with the chest pain, are you in pain now? He will say no. So come back to my structure. How can I help you? First of all, where is the setting? The patient stable angina will come in the A&E, or GP will come to the GP. How can I help you? Some people will say, what is the difference? I told you, A&E is emergency cases. Cases that don't wait. Acute current pain. GP, no. That's why the stable angina, the patient is not in pain now. The patient had pain during exercise and is relieved, so they will come to the GP clinic. So, how can I help you, doctor? I have a chest pain. I'm really sorry about that. Are you comfortable talking to me? Yes, doctor. The most important key question between MI, difference between MI and stable angina, are you in pain now? No, doctor, I'm not. I'm not in pain now. Now, can you please tell me more about the pain? The patient will tell you the description of the pain that is not similar to the description of the pain for MI. So, he will give you the pain, doctor, chest pain. He will give you the central pain, chest pain. When you talk about it, he will tell you, when you ask him anything that makes it worse, exercise, specific. Doctor, when I do exercise, so number one, the patient is not in pain now. Number two, the pain is increased with exercise or initiated with exercise. Number three, relieved with rest. So when he is resting, the pain is relieved. That's it. That's it. So please bear in mind this very important point that the patient will tell you. The symptoms are relieved by rest. All right. Then after that, you will go to shortness of breath, cough, fever, heart attack, trauma. Ask all these questions. Then go to differential. Then P2. So now we know the specific questions for angina. He is not in pain now. Pain started with exercise. Pain is relieved after rest without anything. Okay? Now, in this case, because the patient is not in pain, data and details. By the way, P2, past history. Have you had such pain before? You will say yes. Few times. And all the time, whenever the patient gives you positive finding, when you say yes, can you tell me when it happened, what were you doing? So explore. If the patient gives you any positive, the patient gave you, explore. Then when you explore, in the past history of chest pain, yes, he had it before, yes, it was during exercise. Then I'll go to past medical condition, he will give you positive everything. High blood pressure he will have, cholesterol he will have, diabetes maybe. Then when you go to DESA, should I ask DESA? Yes, do, because it's a chronic. It's something not acute. Ask DESA, it will be all positive, then Maftosa, MAF, and then in Maftosa, make sure you ask all Maftosa, and then when you go to expectations, doctor, I want to know what's happening, examination, examine the vital and examine the chest, everything will be normal. Then they have an idea what's happening, no doctor, and then he will say, doctor, is a heart attack, that's one concern. Then provisional diagnosis, again, it is decrease in the blood supply, that's going to the heart. Okay, so basically, this pain, clue in the history of the angina, the patient is not in pain now, no symptoms now, the pain only in exertion, it lasts for 5 to 10 minutes, relieved on rest. No sweating, no vomiting, no nausea, nothing. Okay? Observation, management, no admission. He doesn't need admission, yeah? So, he doesn't need admission, yeah? But you can put him under observation, okay? So, in the GP clinic, you cannot observe. So, if he came to the A&E, he will not. But in the GP clinic, will he need admission? No. He will go home. Number 2, you will talk to senior. Number 3, you will run investigations. What are the investigations? Exactly the same as MI investigations. Okay? Full blood count, cholesterol, urea electrolyte, very important, clotting profile, and the most important point here is heart attack markers, ECG, chest X-ray. ECG, chest X-ray. Don't forget cholesterol level, blood sugar level, urea electrolyte, full blood count, very important heart attack markers. Then treatment, step 4, symptomatic. So I will give him GTN. GTN when? Every time he has chest pain. So when needed. Aspirin, statin. So GTN when needed. GTN when needed. Aspirin, statin. Alright? Now, don't forget to talk about, I said, step 4, symptomatic plus lifestyle. So symptomatic, GTN when needed, whenever he has the pain. Whenever he has the pain. Whenever he has the pain, GTN. Okay? So whenever you have the pain, have this spray. Okay? GTN. And don't forget that plus lifestyle. So on the lifestyle, I will talk about DASA. If his diet is not good, talk about it. If his exercise doesn't do, talk about it. Smoking, alcohol, talk about it. And now further, I need to manage further things like what? This patient will be on aspirin, exactly like the MRI. Aspirin A, ACE inhibitor, atorvastatin as A. So A, B, C, D. What's A stand for? 3 things. Aspirin, atorvastatin, ACE inhibitor. B, bisoprolol may be for beta blocker. C, clopidogrel may be needed as well. D is for DASA, okay? And specialist, heart specialist referral, who will do stress test or exercise test. What is that? What is that? It's ECG under stress. They ask the patient to do exercise and they do ECG, image for the heart. So stress test and echo, and echo. And this patient might need angioplasty. And this patient might need angioplasty. This patient might need angioplasty. Okay? Okay, so should I talk about driving, exercise, and sex? I want to differentiate. If the patient said to you, doctor, the patient who has a stable angina, should I stop of work? No. Should I stop driving? No. Should I stop exercise or sex? No. Only GTN when you have pain. So, no problem with exercise, no problem with work, no problem with sex, no problem with driving. Only you have the GTN spray when you have pain, have it. But with MI, work, they stop 2 to 3 months. Sometimes it goes to up to 6 months. Driving, 4 to 6 weeks. Sex and exercise, 4 to 6 weeks. So 4 to 6 weeks for sex and exercise and driving, and 3 months for work. Okay? A stable angina, nothing. Safety netting for angina, safety netting for angina, safety netting for angina, MI. Always safety net for patient with angina, MI. So safety net them for central crushing chest pain, going to the left shoulder or going to the left hand, please come right away. Safety netting. Always follow the management structure. Okay? Okay. Then the third station is PE. The third station is PE, chest pain PE, chest pain PE. So how can I help you, doctor? I have a chest pain. It will be A and E case, okay? A and E case, chest pain. So explore the chest pain. Can you please tell me more about it? The patient will give you Socrates. Socrates. Whatever he gives you, if he gives you the site and the onset, carry on the rest. Explain or explore the rest in details, Socrates. And when you ask Socrates, I said, always ask site exactly. Always ask about the character. Always ask about the radiation. Does it go to the left shoulder, left hand? Always ask about anything that makes it worse, anything that makes it better. Then anything else, he will give you shortness of breath and sometimes a cough and hemoptysis. So PE sometimes they present with cough and hemoptysis, yeah? So he will give you shortness of breath, yes. Cough sometimes with hemoptysis, okay? Then exclude everything, again, chest outside to inside as differential, but not all of them. P2, P3 maftosa, but be careful because there are positive findings that I will find in a PE case. So a PE case, what are the positive finding of a PE case? And by that, I will involve what will come to you in history. Number 1, in history, you will find the patient is on medication. Like what? OCP is a risk factor. HRT is a risk factor. Or maybe the patient is on blood thinner is a risk factor. Okay? So please, OCP, HRT, blood thinner. OCP, HRT, blood thinner. And recently we have a new station where the patient is basically transgender and she is on estrogen. So using estrogen. So estrogen, not the patches, the tablets. So the patient is on estrogen tablets, using estrogen tablets. Transgender patient, using estrogen tablets, and the estrogen is one of the medication that can cause PE. So presenting with PE when you take history, so medication is very important as a risk factor. Medication. So when you take history of PE, risk factors number 1, medications. Don't forget medications. What are the medications? She may be on OCP, HRT, blood thinner, or the patient might come presenting with PE, with chest pain, shortness of breath, and when you take history, doctor, the patient is changing the gender, and for that, the patient is using estrogen. Second risk factor, family history. Family history. So M is done, medication. F is family history, risk factor. Risk factor. Family history of what? Of blood clot in the heart or lung, or family history of bleeding disorder. Another risk factor, the patient has DVT, current or previous DVT, or leg pain. So the patient is having leg pain, or he gives you or she gives you past history of DVT. Another risk factor, a third risk factor, the patient is immobilized, pelvic surgery, hip surgery, immobilized, admitted in the hospital, okay? Recent surgery, the patient is not moving, travel history, being on a plane for a while, all these are immobilization. So the patient is immobilized. For that, it is a risk factor for PE, and smoking is a risk factor. So these are the risk factors it will be given to you in history. Now, what is the management of PE? What is the management of PE? 1, follow the structure. Number 1, admit. Number 2, talk to senior. 3, investigations. What are the investigations? Blood, urine, stool image, blood, all the blood, full blood count, cholesterol, blood sugar, urea electrolyte, but mainly D-dimer and CTPA. Mainly D-dimer. Leave the CTPA because it's not blood. Talk about the blood. D-dimer, ABG, heart attack markers, like what? Like troponin. So D-dimer, heart attack markers, okay? Heart attack marker. Doppler on the leg if there is DVT. Okay, so now come to the image. So in the blood we spoke, in the blood, full blood count, cholesterol, urea electrolyte, blood sugar, and very important, clotting profile. D-dimer, heart attack markers. Clotting, D-dimer, heart attack markers. In the image, we need Doppler on the legs, okay, because it can be DVT. Doppler, ultrasound on the leg. On the image, you will need chest X-ray, ECG, chest X-ray, ECG, and the consultant may ask for CTPA. That's a further specialist investigation, CTPA. Step 4 is symptomatic plus lifestyle. Symptomatic. What is the symptomatic? This patient will need oxygen. This patient will need IV fluids, painkiller, morphine. This patient will need heparin, low molecular weight heparin, subcutaneous, low molecular weight heparin subcutaneous. But before that, we'll start with IV bolus of unfractionated heparin. So in the management, I will give morphine for the pain, oxygen, IV fluid sometimes, and don't forget I will give IV unfractionated heparin, followed by low molecular weight heparin subcutaneous for some time. Okay, so don't forget that the patient will need referral, specialist, chest specialist, and the patient, you will talk to the patient, you will need referral, and hematologist sometimes, blood specialist, okay? Safety net for that similar condition, safety net for similar condition, but be careful because I have said step 4 is what? Symptomatic plus lifestyle. So on the lifestyle, what do you need to do? In the lifestyle, advice about the risk factor. So in the lifestyle, if the patient is on medication, like OCP, if the patient is on estrogen, you're gonna advise about these things, okay? However, be careful because in cases of PE, you need to tell the patient that you will be on long-term anticoagulant. So for now, I would like to tell you the management. The patient now will be giving oxygen, morphine, IV fluid. What else? The patient will be given IV unfractionated heparin, and then followed by subcutaneous Lomacot heparin. And this patient will be on long-term blood thinner like what? Like warfarin or apixaban. Okay. So, and as I told you, risk factor for P is estrogen, not the patches, but the tablets. Now pericarditis. A patient will come to you with chest pain, and it is a pericarditis case. So, 45 years old, 35 years old, 40 years old, presented to the clinic with, or the NE with chest pain. How can I help you? Doctor, I have a chest pain. Sympathy, empathy? Yes. I'm really sorry about that. Are you comfortable talking to me? Yes, no. Can you please tell me more about the pain? He will give you the pain, characteristic pain. He will tell you, doctor, it's chest pain in this area that is relieved when I lean forward. Characteristic. So chest pain relieved when I lean forward. Okay. Now, the patient will give you characteristics. What are the characteristics? He will give you recent viral infection. That's for the push countries. Recent viral infection. So 3-4 weeks ago, he had viral infection. Or recent TB infection. Or anti-TB drug. What do you mean? So the patient who had recent viral infection, that's the risk factor. The patient who had recent TB infection, it's a risk factor. And also being on anti-TB drugs, medication that is treating TB is a risk factor. So the TB is a risk factor, that anti-TB medications are risk factor. Viral infection risk factor. What else? Previous heart attack is risk factor. So this will be all. So the characteristic pain we know. Pain, chest, relieved, leading forward. The patient will have past history of MI, or the patient will have previous flu-like symptoms, previous TB, or previous treatment for TB. Okay? Management of pericarditis and provisional diagnosis. Pericarditis is what? Is inflammation on the covering of the heart, okay, which is pericarditis. So basically, this patient will be admitted. Doctor, all patient will be admitted? No. How many risk factors I've given? There is a risk factor, uremia. Uremia is one of the risk factors for pericarditis as well, yeah? So, pericarditis, admit or send home depending on what? The cause. If the cause is viral or previous TB or anti-TB, home, after observation. I will observe, then send home. If the cause is uremia or previous MI, admit. So again, how many causes, how many risk factors for pericarditis? We said previous viral infection, previous TB or anti-TB drugs itself can cause, MI, uremia. If the cause is MI or uremia, while you're taking history, previous MI or uremia, admit. If the causes of the pericarditis, is viral or TB, send home. Okay? Now, talk to senior, all of them talk to senior. Step 3, investigations. What are the investigations? What are? Blood, urine, stool image. Blood, full blood count, cholesterol, urea, electrolyte. Be careful that you need to do heart attack markers, clotting profile. Heart attack markers, clotting profile. Blood, urine, yes, urine. Stool image. In image, I need ECG, and in the ECG, it will be saddle-shaped ST elevation. Saddle-shaped. So, this is, for example, the ECG P QRST. It will be saddle shape ST elevation. So this part will be like this. So P QRST. You see this? Saddle shaped. So saddle shaped ST elevation. So ECG, you will be given saddle shaped ST elevation. Okay? Or so saddle shaped ST elevation, or alternating R wave, tall and short. So the R wave alternating, every other one it's tall and short, tall, and short. One tall, one short. One tall, one short. That's the what? The R wave. The R wave. Okay, so be careful because you'll be handling an ECG. Mostly it will be the ST elevation subtle shape. Okay, and now as I told you, PQRST. So the R wave, as you can see, the R, one long, one short, one tall, one short. So tall and short alternating. One tall, PQRST, tall, and the second T will be short, alternating. Okay, so that will be given to you. Now investigations. Step 4, treatment, symptomatic. So painkiller and anti-inflammatory. So this patient will be giving NSAID or ibuprofen. So NSAID in brackets ibuprofen. So the patient will be giving NSAID. If it's not improving after 14 days, we give colchicine. If it is still not improving, we will give steroids. So that's your treatment as an FY2. NSAID, ibuprofen, not improving after 14 days, colchicine, not improving, steroids. Referral? Yes, referral to specialist. Cardiologist who will do echo. Why? To look for complications. Because pericarditis can complicate to pericardial effusion, heart failure. So referral to cardiologist, heart specialist. Why? We'll do further investigations like echo to exclude complications. All right. Musculoskeletal chest pain. The next case. By the way, pericarditis safety net for MI. Okay? So pericarditis safety net for MI. Next station. 30 years old. Andrew presented to the A&E with chest pain. Now I'm discussing with the case of musculoskeletal chest pain. So, how can I help you? Doctor, I have a chest pain. Sympathy, empathy. And don't forget, are you in pain now? You will say yes. Sympathy, empathy. I'm not sure about that. Are you comfortable talking to me? Or would you like me to give you painkiller? Yes, I am comfortable. Yeah, brother, I am comfortable. Then, Socrates. He will give you chest pain here. Okay? The site, muscular, pectoralis major, this area. Onset, he will tell you started yesterday, doctor. It's not acute. Character, stitching pain, for example, or cramping like pain. Radiation, no radiation. Anything that makes it worse or better. Movement makes it worse. And then severity, 6, 7. And then just before the pain, what were you doing? Or, for example, he will give you that the pain started yesterday, and yesterday he was playing squash. So usually young patient who has been physically active or exercising or had a trauma. Okay? So that's the only thing. So the only positive thing that is that he's physically young, physically active, just had exercise yesterday, he was playing squash yesterday, or he had a trauma yesterday, whatever. Okay? When you ask him anything else, no. Shortness of breath, negative. Cough, negative. Fever, negative. Heart attack, negative. Trauma, as I told you, the only positive thing is trauma or exercise. But obviously, he doesn't know that the exercise is the cause. Okay? When you ask questions, everything is negative. When you go to P2, sometimes it's confusing because he will give you history of MI. Yes, my dad had MI, so you must exclude MI. And as I told you, every single patient that walks through the door, if the patient is having chest pain, you must exclude MI. Okay. Now, management. Management is going to be in the NE. So observe the patient. Chest pain. The pain will come, the patient will come, pain on the left side. So observe. Don't send home. Chest pain as an SHO, don't send home. Observe. Senior. Investigations. What are the investigations? All bloods. Full blood count. Clotting profile. Urea electrolyte. Cholesterol level. Blood sugar level. All blood. All bloods. Urine stool. Image. ECG which will be normal, ECG, which will be normal, chest X-ray. Okay? Don't forget the heart attack markers in the blood. You must, as I told you, if you have any patient with the chest pain, always ask about MI, safety net for MI. So your first question to execute MI, safety netting MI, investigations MI, MI is everywhere. So heart attack markers, ECG, chest X-ray. Don't forget all the bloods, including heart attack markers, ECG, chest X-ray. Okay? Now, step 4, symptomatic plus lifestyle. So painkiller, the patient will need painkiller, paracetamol. Okay, ice pack wrapped in a cloth to reduce the symptom. Ice pack. Avoid strength exercise. So avoid exercising for now. What if not improving? Referral, specialist referral, because they may need a steroid injection. But you don't need to talk about this. Okay? So as simple as painkiller, ice pack, have a rest. Okay? Always safety net for MI. So start with MI, end with MI. Any chest pain case, start with MI, end with MI. Finally, and the last station, chest pain, post-herpetic neuralgia. Post-herpetic neuralgia. How can I help you? Doctor, I have a chest pain. Explore the chest pain. Are you in pain now? Tell me more about it. Are you in pain now? Socrates, the patient will give you. What are the positive findings that the patient will give you in history? Positive finding. Unilateral chest pain. Unilateral chest pain. Number 1, unilateral, one side. Post shingles, the patient will give you past history of shingles. Post shingles. He will tell you that the pain is burning in character or electric shock. So character will be burning sensation or electric shock like pain. So I'm giving you the positive that will be there in history. Electric shock like pain. Burning. Yes. It is irritated by overlying clothes. Doctor, the clothes causes irritation for this pain. Okay? And he will give you, when you ask about the site, so the character we know, burning like, electric like, the site, he will give you the distribution of dermatomal distribution from front and back of the chest. Dermatomal, it follows the dermatome, but never crosses the midline. The pain never crosses the midline, okay? Usually in old patients, so the patient will be old. Always exclude what? Always exclude what? MI. So always exclude MI, So MI must be excluded in history, and always safety netting for MI because the patient will be old age, okay? And always, as we know, same structure. How can I help you? Pain. Ask about the pain. Site, he will give you dermatomal distribution. Character, onset, a while ago. Character, he will give you electric pain or a pain like burning sensation. Then always exclude MI. Always ask about the radiation. Does it go to the left shoulder? Always. Ask the 5 questions and everything, okay? Now management. No referral, no. Senior, yes, all the cases. In the management here, I will give, here is the pain control. So here, the main thing is pain control. Pain and advice, yes. No investigations needed, nothing is needed. Just pain management plus advice. Pain management is the thing here. So post-herpetic neuralgia, your main core is pain. So pain control is the main thing here. So I will give him paracetamol plus or minus codeine, which we call it cocodamol. So I will give him paracetamol plus or minus codeine, which is called cocodamol. So cocodamol is one of the painkiller that will be given if it's not really severe. However, we will be giving a local preparation, lidocaine patch, or lidocaine cream. So lidocaine patch, lidocaine cream, painkiller like cocodamol, and in severe cases we can give nerve painkiller like what? Amitriptyline, gabapentin, if the patient is not improving at all, tramadol. So again, painkiller, So the patient here, the management is two things: pain management and advice. Pain management, I will start with medication as simple as paracetamol plus or minus codeine, in brackets like cocodamol. The patient will be given lidocaine patch, lidocaine cream. Not improving, not improving, not improving. I'll be giving the nerve painkiller like what? Amitriptyline, gabapentin. Not improving. Worst case scenario, tramadol. Okay, but don't jump. Don't give him all the options. So don't jump into tramadol. So talk about lidocaine patch, lidocaine cream, cocodamol, nerve painkiller. Okay. Advice: loose fitting clothes, wrapped ice pack or frozen peas wrapped in towel. They bring a towel, and they put frozen peas or ice pack, and then they put it on the chest. So that's wrapped ice pack or frozen peas in a towel and put it on the area. Okay? And always safety net for MI. Always safety net for MI. Always safety net for MI. So what I would like you to know, just to recap, whenever you have a patient with chest pain, very important question: are you in pain now or not? Very important to exclude MI. Very important to exclude MI. How? When you ask Socrates, cite exactly where it is, character, time of pain, radiation. Very important. Whenever you have any pain, anywhere, in the chest, in any patient, chest pain, you must exclude MI to be a safe doctor, because PLAB 2 is about being safe doctor. Safe doctor. Don't miss life-threatening condition. So whenever I have a chest pain, I will exclude MI. One thing you must, even if it's a muscular, even if I know he's played exercise, he played the squat, it's MI must be excluded. Whenever you have any chest pain. Whenever you have any chest pain, always ask after the pain the 5 symptoms, because they will give you differentials anyway. Every case has positive. I told you about the positive. With every situation, there are positive findings. Always, data must be asked only in chronic, not acute. In every case, verbalize examination. In every case, when you manage heart attack markers, ECG, chest X-ray. Heart attack markers, ECG, chest X-ray. In every case, it's a chest pain, painkiller. Chest pain, painkiller. And then manage accordingly. If it's a pericarditis, colchicine NSAID. If it's a PE, Lomacot heparin, start with IV heparin and then Lomacot heparin. If it's MI Mona, and then in all cases, further referral to cardiologist, except for the post-herpetic neuralgia and the muscular, I will refer to cardiologist to do further investigations in every case in the station with safety netting for MI. Alright, guys, thank you very much. I hope the chest pain is covered. I'm sorry, I'm trying to be quick, okay, because I want everything to be focused and I want you to have time for practice. That's why I am trying my best to condense things, okay, so you can finish the course early and you can start with practicing and you go ahead with practicing nicely. All right, thank you very much. Thank you.